So I realize that it might be helpful for our speakers and for all of you to know who's in the room. So how many nurses do we have with us today? Great. Good. And how about social workers or, great, okay. Wonderful. Therapists with other degrees other than social work. So excellent, great. How about nurse practitioner or physician assistant? Good. The MDs in the room? Great. Pharmacists? One more pharmacist? Okay, you're carrying a heavy load there. Have I missed someone? Educators, so maybe in the school system. Excellent, good. Did I miss anyone? There was a hand, okay. Great, so that shows us that we are actually here together. We can't solve this issue of helping and supporting folks with what we've created, the prescription drug epidemic, and I'm really honored to introduce Anna Lembke. I heard Anna, I think in January when I was getting my X license, and I just was like, oh my gosh, this person needs to come and teach us all. So thank you for coming. Anna's at Stanford, has a Chief of Addiction Medicine program. Thanks so much, Anna. Really happy to have you.
It's my honor to be here today to talk to you about this issue. The United States is facing the worst opioid epidemic in US history. And I think it's really essential to try to figure out what caused this epidemic in order for us to begin to really get at the root of this problem. This epidemic is first and foremost an epidemic of overprescribing. So prior to 1980, doctors were very reluctant to prescribe opioids for fear that patients would get addicted. By the end of the 1990s, doctors were dispensing opioids like candy to anybody who came in and said, I have pain. Today, we have doctors writing more than 230 opioid prescriptions annually, and we as a country consume over 80% of the world's opioid supply, despite constituting less than 5% of the world's population. The good news is, just in the last couple of years, the amount of prescribing has plateaued and even gone down slightly in some states. Nonetheless, we are still prescribing 4 times as many opioids as we did even 10 to 15 years ago. So when we think about what caused this epidemic of overprescribing, we'll hear a lot about the role of big pharma and its advertising to physicians and directly to consumers. We'll hear about pill mill doctors willfully exchanging prescriptions for cash, doctors who have lost their moral compass. But I would argue that those reasons are really just the tip of the iceberg. That this prescription opioid epidemic is in fact a symptom of a faltering healthcare system. And in order to get at the root of the epidemic, we really have to understand the invisible forces driving the epidemic. So that's what I'm going to talk about next. This was just a study that we published in JAMA looking at who is prescribing opioids, and what we found is that everybody's prescribing opioids. It's across the board. There's not a small subset of prolific prescribers driving this epidemic. It's all of us. By volume, it's family medicine doctors because there are more family medicine doctors than any other type of doctor in this country. By specialty, it's pain doctors, which makes sense. So I'm going to talk about 4 invisible forces driving this epidemic. The first is the Toyotaization of medicine. Over the last 3 decades, there has been a mass migration of doctors out of physician-owned practice into large integrated healthcare centers. And throughout this talk, when I use the word doctors, I'm really talking about all healthcare providers. So this transition out of private practice into managed care has had a huge impact on the way that we practice medicine. Basically, medicine has become assembly line care. We're now driven by protocols. There's enormous pressure to get patients in and out quickly. Our care is dominated by what I call the P paradigm: palliate pain, prescribe pills and perform procedures because that's what gets paid, protect privacy, and please patients. A couple of years ago, my son Googled my name on the internet. And he said, "Mom, hey, is this you?" And I came over and I looked at the screen, and there was a patient evaluation of me on Yelp. And that individual gave me 1 out of 4 stars. Plus, they had a comment about my care. "This doctor will make you wish you had never sought help in the first place. Wrong diagnosis, wrong medication. This is dangerous. Seek help from someone else." Obviously, I felt an enormous amount of shame. And when I travel around the country now and encourage doctors to prescribe fewer opioids, they say to me, "Dr. Lembke, I'll prescribe fewer opioids when you can promise me that my patients will still give me a good rating on the patient satisfaction survey." So I think it's really important to take a moment and think about how this kind of medicine is impacting the care that we give. The good news is that my son came up to me about 10 minutes later and said, "Don't worry, Mom, I just gave you 4 out of 4 stars." Twice. The other invisible movement inside medicine, which I think has played a crucial role, is the tyranny of evidence-based medicine. When I was a medical student at Standford in the 1990s and we would round on patients, it was impossible to have any thought at all about patient care unless you came up with a peer-reviewed article to support that thought. In theory, this is going to be great medicine because we're going to base it in science with a capital S. The problem is that science has become co-opted by special interests like Big Pharma and the medical device industry. The other problem is that we've completely negated the value of clinical experience and gut intuition to the point where we can't even enlist our common sense. I myself have treated patients who were literally nodding off asleep during my interview because they were so intoxicated with opioids, and yet I didn't see what was right before my eyes. Big Pharma managed to infiltrate big medicine Trojan horse style in order to perpetuate several myths about opioids. The first myth is number 1, that science proves that opioids work for chronic pain. That is not true. Opioids are great treatment for acute pain. There is no evidence to support their use long-term for chronic pain. Now, I do not want to negate the experiential knowledge of anybody in this room because I think it's incredibly valuable, and you probably have patients who do benefit from chronic opioid therapy, meaning daily therapy for more than 3 months. What I want to emphasize to you is that it is a myth that that kind of treatment is based in the evidence, whereas we have tremendous evidence showing that chronic opioid therapy is associated with a lot of risk factors, including addiction and death. The other myth is that no dose is too high, that if your patient responds and then they come in and say that I've built up tolerance, it's not working anymore, just go up on the dose. And the real tragedy of this is that we now are seeing patients, as I'm sure many of you have, on astronomically high doses of opioids for decades. This is all a result of those myths perpetuated by Big Pharma, who infiltrated CMEs, infiltrated the Joint Commission, enlisted the companionship of the Federation of State Medical Boards, and even swayed the FDA on this issue. Other myths include this idea that somehow the prescription pad confers some kind of magic halo effect, that if a doctor is writing a prescription to a patient for a real medical condition, there's less than 1% chance of getting addicted. We now know that's not true. About 20 to 30% of patients taking opioids for a bona fide medical condition prescribed by a doctor will end up misusing those opioids, and opioid misuse is the first step on the pathway to addiction. Okay, the other invisible force number 3 that I'm going to talk about today is what I call the medicalization of poverty. Starting about 3 decades ago, poor individuals in this country recognized that they could make more money by going on disability than they could make in low-wage jobs. That then gave them incentives to adopt the sick role in order to pay the bills. Now, in order to validate their sick role status, many of them had to go on medications like opioids. Furthermore, that's the very subset of individuals who's at highest risk to develop addiction, because we know that poverty and unemployment are risk factors for addiction. We now have over 40 million people in this country receiving disability for some kind of healthcare condition. The vast majority have mental illness and chronic pain. In the 1950s, The number 2 reasons for disability were cancer and heart disease. So we have legions of people who are now adopting the sick role, probably unconsciously, just as a way to survive. I would also argue that doctors are now incentivized to use opioids to deal with psychosocial, socioeconomic, and psychospiritual problems. Essentially, medicine has become the new social safety net. Many of us are faced with patients who don't just have chronic, complex medical conditions, but are also unemployed, dealing with multi-generational trauma, and even homeless. And yet we are not given the tools and resources to target those problems. All we have is this pill. And so in our desperation, faced with these overwhelming problems, we have to biologize and medicalize problems that are not actually medical. And we give a pill because it's the least that we can do in an overwhelming situation. Finally, I would argue that the 4th invisible force driving this opioid epidemic are new illness narratives about pain. We now believe that pain is dangerous, that experiencing pain has no positive value in our lives, and furthermore, that anybody who experiences pain is left with a kind of psychic scar that sets them up for future pain, especially chronic pain syndromes. Now, whatever you may think about the increasing numbers of young, otherwise healthy people who are coming into our offices talking about being in pain from the tips of their eyelashes to the tips of their toes, you need to recognize that it's a brand new and highly modern phenomenon. Even the concept of chronic pain didn't exist in the 1800s. And at that time, doctors actually believed that some degree of pain was salutary. They believed that pain boosted the immune response, that it boosted the cardiovascular response, that what doesn't kill you makes you stronger. We have completely lost this concept. We believe that all pain is dangerous and we must do whatever we can to eliminate pain in our patients. On top of that, we have a narrative that says that doctors can fix anything. Aided by technology, doctors can fix anything that's wrong with you. So I do believe that to really get at this epidemic in a meaningful and sustaining way, we need to get at these invisible forces. When we think about the Toyotization of medicine, assembly line care works great for hip replacements, cataract surgeries, pneumonia. It will never work in its current model for chronic illnesses like chronic pain, depression, and addiction. We need to be able to create a chronic care model within the House of Medicine, train our doctors to treat chronic pain, and pay them to do so. When it comes to the tyranny of evidence-based medicine, let's push back on that. When someone asks for evidence-based, let's say, you know what? I've been working in medicine for 25 years, and I can tell you that this is what works. And it's okay to say that. You don't have to feel bad. You don't have to quote 4 studies. And when you do quote studies, make sure and look at the veracity of those studies and whether or not they were implicitly, indirectly, or directly funded by Big Pharma. Yeah. Woohoo! Let's get rid of evidence-based medicine, bring back clinical intuition. When it comes to the medicalization of poverty, I think we really need to ask ourselves as a society, do we want medicine to be our social safety net? And if the answer to that is yes, then we have to give healthcare providers the tools and resources to treat the problems that our patients really have, not biologized problems, in order to justify doing anything at all. And then finally, in terms of illness narratives, I think we need to bring back some new narratives. That pain in some circumstances can have a useful and positive value in our lives, if only to remind us what joy looks like. That people are resilient, that the body can heal itself. And finally, that doctors are limited in their ability to fix what's broken, and when they try to go beyond those limits, they can make things worse. You and I know that, but our patients don't, and we need to re-educate them on those fronts. Okay. So now we've been looking at the 30,000-foot view. I'm going to shift gears a little bit and talk about you in the room with your patients. And when I say you, I mean you and me. And I'm going to talk about you and me as the compassionate doctor. So people who basically fundamentally are pleasers by nature, but also people who are pretty good at figuring out large, complicated systems and working their way through that maze in order to get through the schooling that you need to get the degree in the first place. So we're pleasers and we're good at figuring out systems. We're also people who generally go into medicine because we're responding to a higher calling, right? We want to help people and we want to alleviate suffering. That's why we chose this field. As we go through our medical training, we're highly socialized to empathize with our patients. We're absolutely not trained in how to detect manipulation or deal with it when it occurs. And finally, what keeps us going, I know what keeps me going, and I'm guessing it's true for a lot of you, is what I call mutually affectionate relationships. For all of the garbage that we have to deal with on any given day, from prior authorizations to medical justification to calling pharmacies, I know what keeps me going is that mutually affectionate encounter with a patient when I feel I've really been able to help them and they feel that they have been helped and can express some gratitude. The philosopher Martin Buber talks about this as an I and now moment. I'm going to read you a quote, which I think quintessentially captures that moment between patient and provider when things are going well. Man wishes to be confirmed in his being by man and wishes to have a presence in the being of the other. Secretly and bashfully, he watches for a yes, which allows him to be and which can come to him only from one human person to another, from one human person to another. The power of healing that comes from that human relationship. Okay, so now you know who the compassionate doctor is. Who is the drug-seeking patient? The drug-seeking patient, I would contend, is by and large somebody who truly is suffering and is coming to us for help. But what has happened is in the process of trying to get help, they are now becoming addicted to the very medication that we are prescribing. How can we understand addiction and frame it as a disease instead of thinking it merely as malingering? The way to do that is to ground it in our knowledge of new neuroscience, which shows us that the reward pathway is like a balance in the brain. And when the balance gets tipped to the left, we experience pleasure. When it gets tipped to the right, we experience pain. And an overriding rule governing that balance is that it wants to remain level, neither tipped to pleasure nor tipped to pain. And it will go through a process called neuroadaptation to bring it level again after the experience of pleasure or the experience of pain. So if a patient takes an opioid, a highly dopaminergic substance, like all addictive substances are, there will be a very strong tilt to the side of pleasure. Then there will be lots of neuroadaptation. I think of them as little gremlins hopping up on the other side of the balance to bring it level again, down-regulating my own endogenous endorphins, my own endogenous dopamine, so that I can bring the balance level again. Then all is well, I'm back in line, I'm at my usual set point. But what about the patient who is taking opioids daily, weekly, and monthly for a very long time? It's tipping. The amount of neuroadaptation that has to occur to respond to that exogenous opioid is enormous. And after a while, that's a different brain. And that's the fundamental thing to think about. The brain has changed. If that individual now wants to stop using, what happens? All those gremlins over here bring it level, but don't stop there. They continue to go to the side of pain. And that can last a very long time before those gremlins get off and there's readaptation to bring the balance level again. So our drug-seeking patient is not living here with a balance that's level. They're living here with a balance that's in a state of pain. And that pain is what is driving the drug-seeking behavior. And I think that frame for me has been very helpful in order to preserve my compassion in the face of being lied to and manipulated. Now I'm going to talk about some strategies that patients use in order to manipulate their doctors to get prescriptions. You may recognize some of these from your own experience. I know I recognize many of them, but only in retrospect. For all the time that I've been doing this work, I still can't tell who's lying. And I'm kind of a skeptical, suspicious person. One of the common techniques is filibustering. This is waiting to the last 30 seconds of the visit to ask for a refill because they know yes takes 30 seconds, right? And no will add another 30 minutes to my schedule. Flattering speaks for itself. You're the best doctor. You're so much better than my other doctors. Demonstrating. These are patients who undress in your office to show you their wounds and their scars and writhe on the ground. They cry. Teaming up. These are the patients who come in with their mothers. The mom is crying. The patient is writhing. The city mouse and the country mouse. The city mouse is that sort of naive individual who you would never guess in a million years would be addicted to drugs. The city mouse is that individual who goes into the ED and says, I'm allergic to all meds, all pain meds except for IV dilaudid push with a Benadryl chaser. Losing meds speaks for itself. These are the patients who are again and again telling you, I lost my medication, doctor, I'm so sorry. Water is a very common theme here. It went down the toilet, it went through the rinse cycle, fell in the bottom of my fishing boat. Calling weekends and evenings. In our large integrated healthcare system, we're doing shift work now. This is a very good strategy. You just wait till nighttime when a tired resident or an on-call doctor will do anything to just get off the phone. Seeing a mirror image. This is other healthcare providers, nurses, doctors, people in our field. They drop the same names. They went to the same schools. Hard for us to second guess those individuals. Doctor shopping, you all know this term, people who go to multiple providers to find the same or a similar prescription. And then bullying, this is probably the most effective strategy. These are the patients who get angry, who threaten to sue. At my particular hospital, these are the patients who call patient relations. If I get called to patient relations enough time, I have to go before a committee called the Professionalism Committee, where my ability to care for patients is intimately questioned. Now I actually sit on the Professionalism Committee, so I'm hoping not to get called before it. Okay, so we've talked about what motivates the compassionate doctor. We've talked about what motivates the drug-seeking patient. I think it's fair to say in the larger context of healthcare delivery today that we're all kind of caught between a prescription and a hard place. And since we're human beings, what do we experience when we encounter the drug-seeking patient? We experience a whole lot of anxiety. And like any other human being, when we experience intolerable anxiety, we enlist our primitive defense mechanisms. So defense mechanisms, unlike coping strategies, are unconscious. We're not even aware that we're engaging in a defense mechanism. It happens automatically. It's a kind of a fight or flight response. Coping strategies are things that we have learned to do to decrease our anxiety or our sadness or our rage or whatever it is. So defense mechanisms work great because in that moment, I engage in my defense mechanism, and because of that, my anxiety is decreased, and then I can proceed with what I'm doing. And I would argue that individually and systemically, we have been engaging in numerous defense mechanisms vis-a-vis this opioid epidemic problem. First and foremost is the defense mechanism of denial, just kind of pretending it isn't happening. I know I've done that many, many times. The other is projection. Projection is where I take an emotion that I can't tolerate and I project it onto another human being. And I say, they're having that emotion. I'm not having that emotion. They're having that emotion. With drug-seeking patients, I often feel rage toward those individuals. So instead of owning my rage, which is at odds with my identity as a healer, I project my rage onto that patient. I say, she's a borderline. She's got borderline personality disorder. And then I probably make some snarky remark to my nurse or something after the visit. Splitting, this is very common. This is where I divide my patients into my good patients and my bad patients. My good patients don't take very much time. Their problems are straightforward. They bring me chocolate at Christmas time. My bad patients are my complex chronic pain patients, my drug-seeking patients. They take way too much time. They're not grateful. They make me feel incompetent. Then passive aggression. The most common manifestation of this defense mechanism is procrastination. These are patients that I round on very quickly in the hospital, or maybe I send my fellow instead. I know this patient should really probably come back in a week. Instead, I say, just come back in a month, you'll be fine. I don't return these phone calls. So we've talked about the compassionate doctor and her primitive defense mechanisms. We talked about the drug-seeking patient and her strategies for manipulation. What happens when you get the compassionate doctor and the drug-seeking patient in a room? Well, this is great. We talked about your diabetes, we talked about your hypertension. I put in the referral for the nutritionist, and you're doing great. So I will see you next time.
Gosh,
okay?
You know, you are so good, Doctor. Thank you so much.
Oh, my pleasure.
I just love working with you. You know, you're so much better than my old doctor. You take time to explain everything to me. I really appreciate that. I filled out one of those surveys out at the front desk. They give you the patient evaluation thing, you know. I just glowed about you. I just love having you for my doctor. Just one more thing before I go. Could you refill my oxycodone? I know I'm a couple of days early with it, but my family was in town this week, and oh gosh, my fibromyalgia has really been acting up. You know, I think it's probably because of all the extra cooking and cleaning I had to do while the kids were in town. You know.
Okay. Yeah, I'm not sure that's a good idea. I think I just gave you an early refill last month. I mean, I'm not sure. I'd have to check the computer.
No, I don't think so. I don't mean to bother you.
Yeah.
I'm really sorry. I know you're super busy. It's just that my pain has been so bad, you know.
Yeah, I mean, I hear you about the pain. It's just that, you know, you're at really high doses, and we've gone up a lot on the doses, and I'm starting to think, you know, maybe I need to refer you to a pain specialist. And maybe it's kind of, you know, more than I can treat at this point.
Nobody understands. Nobody understands my pain. My husband doesn't understand. My kids don't understand. I thought you were the one person who understood. I thought I had one person that cared. I wish you could spend just one day in my skin. 1 hour in my skin, you would understand how unbearable this pain is. Now I see you don't even get it. You're just trying to get rid of me, push me off on some other doctor and abandon me.
Okay. I'm not trying to. I'm not trying to abandon you. I care about you. I care about your pain. Okay, I will write you an early refill this time. Okay, but this is it. Okay, this is the last time. Please just take it as prescribed.
I will, doctor. I will. I promise I will.
Because I'm not going to do any more early refills. All right, this is it.
I understand. It's just that with my family in town and the holidays and all the stress of that's all it was.
Okay.
I'm sorry I broke down like that. I know you care about me.
Okay.
I know you really do. You've always been great.
All right. Okay.
So I just said those things because I was scared. I'm sorry.
No, that's okay. Sorry. No, that's okay. I understand. Okay, so really nice to see you, and I'll see you next time.
All right.
Okay?
Thank you.
Yeah,
Thanks a lot.
You're welcome. All right, take care.
Thanks, you too.
All right. Bye-bye.
Bye-bye.
All right. Yeah. Yeah. That, by the way, that wasn't a real patient. I have done some talks where people thought that was a real patient, so for those of you who are wondering. You know, it's so complicated, right? That interaction in the room with patients, and no kind of algorithm or protocol is ever really gonna speak to that. And I would argue that the inauthenticity that I engage in with the patient is part of what contributes to burnout, right? You have enough of those encounters and you know you're not doing a good job. And this patient really is struggling and suffering. And actually, I should ask, how many people in this room have provided that kind of care? Okay, some brave souls. How many people did it last week? I mean, what's amazing to me literally is I go around teaching this and I still get pulled in this way. I really do. It's just a powerful, powerful force. So not something that we want to continue doing, except it's very, very common and hard to avoid. But what happens when primitive defense mechanisms don't work? Like, let's say I check the prescription drug monitoring database and I see that this patient has in fact been going around to multiple doctors. Now there's no doubt about it. I can no longer remain in denial that this patient has a prescription drug misuse problem and that I am complicit in that. Well, because I'm a human being, I become narcissistically injured. I experience what's called a narcissistic injury. Now, you don't have to be and by the way, there's a narcissistically injured, it's highly unconscious, it happens instantly without our awareness, and you don't have to be a pathological narcissist to experience a narcissistic injury. Anything that we invest our energy and creativity and libido in is something which makes us vulnerable to being narcissistically injured, right? It's something that we care about and put time and energy into. So whether that's bird watching or trying to be a good parent or trying to be a good doctor, when we feel threatened in that arena, we can experience a narcissistic injury. And the most common response to a narcissistic injury is rage and retaliation. And our patients are victim to this in us. We're going to do a kind of Groundhog Day repeat, but this time we're going to see what happens when the doctor checks the prescription drug monitoring database. And by the way, I do take time in my visits to actually look at the database together with my patients in a transparent way.
Just one more thing before I go. Could you refill my oxycodone? I know I'm a couple of days early with it, but my family was in town this week, and oh gosh, my fibromyalgia has really been acting up.
Okay, I'm not too comfortable with that, but I'll tell you what, I just got access to a brand new database that allows me to look at all the prescriptions that you've received in the last 12 months in the state of California. So let me just look your name up on that, and you know, that will kind of help me be able to make a decision about whether or not, you know, it makes sense to do more pain meds. Okay, so just give me one second.
Is that something that you can do after I'm gone? I really kind of need to get back to.
No, let's take the time. I think it's worth it to take the time now. Oh wow, wow! I'm surprised. It looks like you've been to see a couple of other doctors to get more opioids, and there's some benzodiazepines, some clonazepam, and
yeah, I can explain
wow.
that. I have a tooth abscess. I went to see my dentist this week, so you know,
okay.
there was
This Dr. Smith. I mean, who's the Dr. Smith?
Oh, Dr.
on there?
Smith is my OB-GYN. You know, I've been going to her for years, and it was just time for my pap smear. So I just had, you know, I had several people I had to see this week, but of course you're the person I count on.
Okay, and who's this Dr. Williams here? And there's a Dr. Jones. I mean, seems like a lot of meds going on. They're the same ones I'm prescribing.
Well, I have a medical condition that involves pain, so this pain medicine is obviously something that I need in order to manage the condition. I don't know why I feel like I have to defend myself about this.
Okay, well, I'm sorry, but I'm not going to be able to prescribe opioids anymore for you. I mean, you're obviously addicted, and I'm not going to be able to. I don't think I can actually treat you anymore. I'm going to have to ask you to leave.
Addicted? I mean, it's not like a drug addiction or an alcoholic or something. This is a medical condition. I'm getting pain medication for a medical condition. I thought I could count on you to help me out with this. These are the only medicines that help with my pain.
I'm sorry, but it is clear, you know, I had no idea that this was going on. Had I had any idea, I would not have prescribed the way I've been prescribing. So I'm sorry, I can't treat you anymore. You betrayed my trust. You broke the pain contract. I'm sorry, you're going to have to leave.
Aren't you a person who's supposed to help take care of someone with a medical condition? Why are you
I'm going to have
me?
to ask you to leave now. Okay, I have my next patient waiting. Thank you. Okay, so also not a great example of good care, right? But it is happening all over the country, creating what is now being called opioid refugees. Patients who are being kicked out of the clinic because they were discovered to be misusing the prescription or using another drug, or legions of doctors now just deciding they're no longer going to treat these patients, they're not going to treat pain anymore. And you know, I understand that. I mean, I get that. But I still believe that we can do better than that, because what's happening is that some of these individuals are now turning to illicit forms of opioids in order to be able to not get high, but just be able to function after decades of that neuroadaptation that we talked about. So the real question is that how can you and I do better? How can we avoid fluctuating from enabling to retaliation and instead find the middle road? I think importantly, we don't want to do this when we encounter addiction. We don't want to reject and retaliate against our patients. Instead, we want to conceptualize addiction as a chronic, relapsing, and remitting disease. And I urge healthcare providers across the country to do this, even if they don't really believe that it is a disease. It doesn't matter. In this day and age, in the House of Medicine, if you don't treat addiction as disease, you're liable to contribute to and perpetuate the problem. Diseasifying problems is how people now get care. So put it on your problem list. The CDC guidelines came out last year. We know that prevention means prescribing and initiating fewer opioids. This is very important. So I know you're all working on this, but actually this is the easy part, not starting people. What's hard is taking care of the many people that we inherit who are already on high-dose opioids and benzodiazepines and stimulants and sedatives of other sorts, plus their blood pressure med, et cetera. So what I would urge you to use, which is what I use in my clinic, is what's called a contingency management strategy, or tit for tat, in encountering and managing patients to whom you are prescribing controlled drugs. What is tit for tat? Tit for tat is a concept borrowed from behavioral economics. When you find yourself caught in a situation where you can't win for trying, you're kind of caught in a bind. And what it basically means is that first, you begin by cooperating with your quote-unquote opponent or patient. Opponent is the language of behavioral economics. And you continue to cooperate with them until at which point they defect, and then you also defect. What do I mean by defection? I mean the patient comes to you and says, please, will you treat me? And you begin by cooperating. And you let them know what the terms of that relationship will consist of. Many times this is called a contract or a pain contract. You can use a formal contract, or you can just discuss it with the patient and document it in your chart. The point is that you and your patient have an understanding of how the relationship will go. You give your patient a month's supply of opioids. They come back a month later. No early refills, no going to other doctors. Urine drug screen is consistent with your agreed upon plan, and you prescribe them another month's worth. However, if at some point you find out that they have deviated from that contract, the important thing here is you cannot ignore that. You must respond in kind. And also you want to respond in a way that's commensurate with the transgression. So if you find your patient has been misusing an opioid that you've been prescribing, don't kick them out of your clinic, but do enforce some kind of swift and immediate sanction in order to bring their behavior back in line. If their behavior comes back in line, then you can continue and return to the original contract. Not every patient who misuses a prescription that you write is addicted. Many times patients will misuse these prescriptions, but with tit for tat, you can bring their behavior back in line and continue to prescribe. What's the evidence for tit for tat? It basically comes from what's called the contingency management literature in the field of addiction medicine. Contingency management is a way of using rewards and punishments to shape behavior. It's very effective in the population of individuals who struggle with addiction. And over the years, we've learned a number of cardinal rules about the kind of contingency management that works best. First of all, punishment certainty shapes behavior better than punishment severity. So it's much better to have a punishment that patients know they're going to get rather than to have a very extreme punishment, like say, I'm going to kick you out of my clinic. Immediate punishment is better than delayed punishment. So you want to do something right away when your patient misuses a medication. You don't want to say, well, because of this, in 6 months, I'm going to reduce the dose. And the punishment has to equal the transgression. Again, swift, immediate sanctions that are proportional to the transgression. And finally, if your patient's behavior is effectively in line after this tit for tat, then you can go back to the original prescribing and again give them 1 month of the drug. So here are some examples of tit-for-tat strategies that I use when my patients demonstrate misuse or aberrant behavior or deviate from our contract. Instead of giving them a month's worth, I might just limit the prescription to 1 to 2 weeks and then have them come back in, or maybe I'll limit it to 1 to 2 weeks and then give them a refill for that 1 to 2 weeks if I have a clinic where I don't have the capacity to see them every 1 to 2 weeks. That's very helpful for these individuals because it prevents them from borrowing from tomorrow to pay for today. People with this problem, when they have a big load of pills, are more likely to take more than if they have a small number of pills that they have to make last for them. In addition to that, again, increasing the number of visits, you can make prescribing contingent on the urine tox screen. You just have to say, before your appointment, you have to go get this urine tox screen, and I'm going to review it, and we'll talk about it before we decide what to do next. If none of that is working, you might want to think about reducing your dose by a little bit. What I hear a lot of from physicians is that they feel that they're held hostage by these patients and that they're forced to prescribe because the patient threatens suicide or threatens relapse or threatens going into life-threatening withdrawal. And I say to you, you don't have to be held hostage. You can reduce the dose by a little bit in a tit-for-tat strategy and continue to do that until at which point the patient either corrects their behavior or they're down to 0. And I have done that. So I don't use the language of punishment because that's the language of behavioral economics and it just sounds bad. But essentially, yes, I say to them, I recently had a patient, for example, who kept testing positive on his UDS for cocaine, and I prescribed him buprenorphine. And we went down to weekly visits, and we did all kinds of psychosocial support, and we said, you need a higher level of care. How about methadone maintenance? His insurance wouldn't pay for methadone maintenance, and he couldn't get there because he didn't have a car and it was too far away, so it was just left to us. I said, okay, you know what's going to happen? Every week I'm going to go down by a little bit on your buprenorphine until your screens are cocaine negative. It worked instantly. And then we went back up. So when his cocaine was negative, we went back up to his dose. So I think part of it is they're sort of testing you to see if you're really going to, it's like parenting, right? It's like a testing. Are they going to do it? And that's why it's really important to do something so that they know you're serious. Okay, so now we're going to take a moment, and Dr. Hastings is actually going to be my simulated patient. I got a grant to do those videos, and the money ran out before I could do the video showing you how you're supposed to do it. So we're gonna sort of try to play that out here, and it won't be very long. And then the last little section, I'm just going to talk about how to taper off of opioids. It's so great to see you.
So should we go to the place where I'm like,
sure, yeah.
My family was here, and I just had to take more. So I'm out, and I'm just hoping, that you'll do what you've always done, which is, early refill. And I'm just really in pain.
You know what? I'm really glad this is coming up now. I just went to this conference on pain management, and I learned a lot. And one of the things that I learned is that when patients start to have a habitual pattern of running out early, that's one of the signs that they may actually be developing a problem with the pills. And so I'm really worried about this pattern. And I've gained some new knowledge and skills about how to handle it. I'd like to share that with you. Would you like to hear that?
I'm not sure. I really just need my pain medicine.
Right. Well, I know, and I care about your pain, and I want to help you with your pain. But the problem with running out early is that can sometimes lead to addiction. And I would be really worried for you that maybe that's the road that you're headed down. And there are a lot of safety issues, too, related to taking more than prescribed. You might even, get to a point where you could kind of slow your breathing and slow your respiration and go to sleep and not wake up again. And I really care about you, so I would hate for that to happen.
I do. I mean,
yeah.
I need them. I need
right.
them now. I don't have any more.
Well, I think one thing we could try is see if with a little bit closer care and monitoring, maybe you can handle your current prescription. So what I'm going to do is instead of giving you the usual month's worth, I'm just going to give you a week of pills. And I'm going to have you come back next week. And if you're able to take them as prescribed for the week, that's going to be really good. That's going to give me confidence that maybe this was just kind of a bad habit that you slipped into. So if you come back next week and haven't been to see any other doctors and you've taken your pills just as prescribed, then maybe we can extend it to 2 weeks. And let's go along like that and see how you do. I would say, though, that if you come back next week and it turns out you still took them early, then I think we really want to look at the possibility that you're becoming addicted to the pills. And by the way, if that's the case, you're not alone. This is a very common phenomenon that happens to people, even when they're getting the pills from a doctor for a medical condition.
I don't know about this. I don't think I have time to come next week. I think I need my prescription like usual.
Right, and the truth is I don't have really a lot of time to see you next week either, because my clinic is totally booked. But I'm going to make the time. I'm going to make the time. We're going to make this happen because I'm seriously worried about you. And I would hate for something horrible to happen to you. So we'll double book you and we'll make it happen next week. I'm really looking forward to seeing you then.
Thank you. Would anybody else have said anything else? Like, what's another thing to throw at Anna?
Stop what? Stop dropping wine.
Meaning? Whining? Yeah.
Oh.
I'm going to run with the
Yes.
mic. We are recording this, so your questions are important.
It's interesting to decide whether to use the term addicted versus dependence.
Right.
Because an awful lot of people are there. It's such a loaded term. To be
Yes.
addicted is to be like dirt.
Right.
And so I wonder, but on the other hand, sometimes it's telling it like it is. How do you respond to that?
So I'm of two minds about that, and it's an excellent point. Thank you. It is a highly stigmatizing term, and people do really get very uncomfortable with that label. On the other hand, I really believe that addiction is a disease, and we need to bring it out of the shadows. And one way to do that is to just be open about it, that it's normative, that people get addicted, that you're not alone, that there's treatment. But I certainly understand the hesitation. I think you just got to go with your gut, whether or not you're going to use that loaded term or whether you're going to use something else. I will say that since the DSM-5 came out, we are making an important distinction between having addiction and having a just physiologic dependence. But truthfully, where you draw the line is really hard, especially in this day and age when many so-called just dependent patients are taking at doses because they were prescribed those doses that even your most severe heroin addict wouldn't be consuming. So it's very tricky to really even know where that is. But on your point of language, I do appreciate that point. I think you just got to go with your gut. Yes.
So goodness, loud mic. What we're not talking about is confronting the patient about the treatment plan. That essentially the patient and you are going along with the idea that medication is the answer to the pain, as opposed to, all right, I'm concerned that the strategy we've been using in managing your pain with these medications is not working. It's very clear, you're telling me, and you're using more and more. We need to look at other strategies for managing your pain.
Yeah, that's an excellent point. I will talk about that a little bit in this last segment that I'm doing, and then you'll hear a lot more about that through the course of the morning. In my mind, I conceptually divide these groups in these strategies into prevention, not initiating, contingency management and monitoring, those patients whom we have either decided that prescribing the opioid is okay for them, or we are just left with no other option. And there are lots of socioeconomic and healthcare delivery reasons why we are left continuing a prescription that we actually don't want to continue. So that's where this contingency management is really helpful. And then, of course, in some ideal world, we have the time and energy to have the discussion about getting off, and I'll talk a little bit about that.
Dr. Lembke, go on with the talk, and then we'll have our question period, if that's okay with folks. Thanks.
Okay, so thank you for that wonderful segue. What I want to talk about now is more the art than the science of how you get patients off of high-dose chronic opioid therapy. These are primarily conceptually patients who are dependent and whom you have determined that getting off is the best course of action. I've developed this acronym called BRAVO to help remember kind of a basic approach. And I think BRAVO is a nice acronym because bravo to all of you for doing this work, and also importantly, bravo to our patients for being willing to walk down this road with us. B stands for broaching the subject. When you first introduce the subject of getting off of opioids with your patients, you need to schedule more time, and you need to make sure you get support from your team if you have the luxury of working with a team, so that you can resist the pull in the room before you go in there, that you can be compassionate, but also be single-minded and determined about having this discussion. I think it's vital to recognize that the vast majority of our complex pain patients on chronic opioid therapy are abjectly terrified to get off of opioids. And those of us who have never been on chronic opioid therapy, I really don't think that we can imagine how terrified they are. So it's essential to validate upfront, I know this is really scary for you, and I know this is even just having this conversation is hard, not to mention the taper itself. When you do that, you really validate their experience and hopefully let them settle down in terms of their immediate emotion dysregulation so that they can actually pay attention to what you're saying. What I've encountered a lot with these types of patients is they go to a doctor who says, it's no big deal. You're only on 90 morphine milligram equivalents daily. It's not that big a deal. It won't be that hard. And I think many of those doctors believe that by saying that, they're going to engender some kind of placebo effect or nocebo effect and make it easier for their patients. For your complex chronic pain patients, that will have the opposite effect. They will feel invalidated, they will be distrusting. Their experience when they have run out of pills is that the opioid withdrawal is worse than death, so you want to spend time validating how scary this is for them. And then I also like to think of Winnicott's holding environment. Winnicott was a famous psychoanalyst who talked about the importance of creating a safe space for our patients. And one of the ways that you do that is to remind them that you're thinking about them outside of the clinical encounter. So I will say things like, I've been thinking a lot about your pain, and I've come to the conclusion that maybe we need to think about getting off. I think that turn of phrase is helpful, because it lets the patient know that you're not acting impulsively or retaliating, but you've really given it a lot of thought because you care about them. Risk-benefit calculator, I'm not going to spend too much time on this, but the essential crux of who to get off of opioids and who to let stay on opioids has to do with whether or not the risks outweigh the benefits. And you have to talk about it in this way with your patients. You have to talk about it as essentially a safety issue. And you're going to hear a lot more about this with the concept of opioid failure and who to determine is in opioid failure and why. But I would just put out these risk factors that are secondary to chronic opioid therapy. And I put tolerance at the top. What is tolerance? Tolerance means needing more and more to get the same effect, or finding that you're not getting the response that you used to get at a given dose. I would argue that the patient who develops tolerance on opioids is a candidate for an opioid taper. That individual will, once they achieve tolerance, never get to a dose that will be sustainably effective for them. And I will tell my patients this. I say, sure, we could go up and you would get relief for a while, but after a while it would stop working again, and now you're going to have a new problem. You're going to have the same pain, and you're going to be dependent on opioids and experience withdrawal. Patients really understand this. I also talk a lot about hyperalgesia. Remember this scale in your brain and how it changes the set point? What happens to people on chronic opioids is that their pain threshold goes way down, and then they begin to experience pain in other parts of their body separate from their original pain condition. And of course, you want to talk about the risks of addiction and death. You want to involve family in your risk-benefit calculator. One of the unique features of any drug that targets the dopamine reward pathway is that patients lose ability to have insight into their own behavior and functionality. This was a Kaiser Family Foundation poll that looked at patients on chronic opioid therapy more than 3 months and asked them which of them were concerned about addiction. 33% of those patients were concerned about their own use of the pills, but 50% of their family members were concerned about the use of their pills. So there you have a gap in there, right? And that's the gap that you want to get at by bringing family members in, because patients will say, I'm doing great. This is really helping me. It's the only thing that works for my pain. You'll bring the family member in and they'll say they're lying in bed all day. They're not engaging in family life. They're like detached zombies. This was an article that we published in American Family Physician talking about the risk-benefit calculator. It's a very easy read if you want an additional reference. Finally, the A of Bravo is simply addiction happens. I think it's very important, a little bit like I did with this simulated patient, is to talk about upfront that number one, what is addiction? Okay, addiction is a complex biopsychosocial disease that can be diagnosed based on the 3 C's. Who here has heard of the 3 C's before? Okay, a few people. It's much easier than remembering the DSM criteria. Just remember the 3 C's: out of control use, compulsive use, and continued use despite consequences. Compulsive use means using a whole lot of your energy and mental real estate, seeking the drug, hiding use, coming down from the drug. So if you have a patient who is showing out of control use, early refills, taking more prescribed, doctor shopping, compulsive use, all of their mental energy goes into their illness and managing their illness out of proportion to the illness itself, and continued use despite consequences, all kinds of medical problems, relationship problems, job problems, and yet still they want to stay on their opioid. Those are the patients that you want to think about as possibly having an opioid addiction. Now, you'll notice that in that definition of addiction is neither tolerance nor dependence and withdrawal, because those are physiologic phenomena that often co-occur with addiction, but are not required to make the diagnosis of addiction. Also, you can have a patient who is tolerant, dependent, and experiencing withdrawal who is not addicted. Would you guys like an example of that? Okay, so a patient who is dependent but not addicted is really many of our patients who have received opioids daily, and really most of us in this room on opioids daily will experience tolerance and withdrawal when we go down on the dose or stop the opioids. That person is not addicted if they're not having consequential use, out of control use, or compulsive use. Likewise, you can have an individual who hoards a bunch of opioids, doesn't take them on a daily basis, and once a month binges on those opioids to the point of unconsciousness and almost dying, but then doesn't die, maybe revived by Narcan, or just doesn't die on that instance, and then on Monday morning goes back to work and continues the rest of the month without taking opioids. That person is addicted without being dependent, okay? Okay, I think it's also helpful to let patients know that there's treatment for opioid addiction. So sometimes tapering people off of opioids is a litmus test for who is addicted. And I say to patients, if it turns out that this is really problematic for you, we might have to consider that possibility, but there's hope because there's good treatment for opioid addiction. I want to add an important caveat to that. Not every patient who has trouble tapering off of opioids is addicted. Some people, because of their physiology on a level that we don't understand, are highly dependent and have extreme difficulty coming off these opioids, and they're not addicted, okay? And I see those patients too. They're no history of addiction, no aberrant behavior, really struggle to come off the opioids. Which gets me to my next point, which is the V of Bravo, velocity and validate. The biggest mistake that most providers make in getting patients off of chronic opioid therapy is to go too quickly. If you read the scientific literature on opioid therapy, what you will typically see is to go down by 5 to 10% of the starting dose per week. I can tell you right now that will never work for the vast majority of your complex pain patients on chronic opioid therapy. Think about that neuroadaptation. These people have been at high doses for decades. You have to go down very, very slowly. I let my patients know that we will be going down, and it probably will take years to get them down. Another important thing besides going slowly is to use the same dosing schedule. I often get asked, well, which opioid should I start with first? The long-acting, the short-acting? It doesn't matter. Whatever your patient wants to do first, that's what you tackle. And that's the other important clinical pearl. Enlist their engagement and let them drive it to some extent. If they tell you, I'd rather stay on my Norco and get off the fentanyl patch first, fine, get off the fentanyl patch first. Go slowly, try to keep the same scheduling because our brains are like little alarm clocks and they're used to seeing that opioid at about the same time every day. So try to go down on the dose but keep the same dosing schedule. Let the patient drive within reason, which means to say that if they say to you, you know what, this is exhausting and I need a break, then take a break. If they say, I have a family event coming up, I really don't want to be dealing with withdrawal when I'm going to that, fine, hang out at that dose for 2 months, 3 months, and then resume your taper again. Importantly, never go backwards. I tell my patients the most important thing here is that we don't go backwards, because if we go backwards, we lose all that hard work that you did. All that hard work kind of resetting the set point, getting those gremlins off, right? So never go backwards. And then sometimes, I'm not going to talk about this today, sometimes patients just can't do it on the Schedule II opioids that they're on, so switching them to buprenorphine as part of the tapering process is and can be a good strategy, although it's complicated by the whole induction process. Methadone is actually a great long-acting opioid to help people taper off of opioids. There's a lot of fear around using methadone now because of the high overdose rates with methadone. So, that comes with that kind of caveat. It's very important that you tell patients what to expect when they're going to go down on the dose. This is another opportunity to validate how scary it is. To tell them what the classic withdrawal symptoms are, but as well as the universal symptoms of withdrawal from any addictive substance, which are irritability, anxiety, insomnia, and dysphoria. But probably most importantly in our chronic pain patients, we have to let them know that they will have increased pain every single time we reduce the opioid dose. Their pain will flare in their usual places and all over the body, but that is not an indication of progression of their underlying pain condition, nor is it an indication of the pain that they will have to live with once they get off of opioids. You can't say this enough times, because here's where the fear comes in. This is the only thing that works for me. Whenever I go down, I have intolerable pain. You have to remind them this is opioid withdrawal-mediated pain, and tincture of time will take care of it. What I usually lay out is a timeline along the line of your pain will be much, much worse, intolerably worse for the first 2 weeks when we go down on the dose. And then in the second 2 weeks, when you get to about 4 weeks, you'll notice that you're sort of settled down back to where you started. This can be very, very helpful to lay it out for them time-wise so that they know what to expect. And then I do a lot of validation here along the lines of, this is really hard, and this is really scary, and good for you for being willing to work on this, because I know this is really hard. Sometimes I'll use a cancer treatment metaphor. I'll say this is a little bit like undergoing chemotherapy for a cancer condition. It's a really, really hard thing to do. You don't get the kind of external validation societally that you get when you have cancer and go through chemotherapy, but it's a lot like that. The idea is this painful treatment will get you to a place where you will be better off. Finally, in the Bravo, very important to, at this point, talk about other treatments for pain. And we're going to hear a lot about that today, all of the wonderful movement strategies that people use, non-opioid medications, psychotherapy, acupuncture, massage, trigger point, tai chi, qigong, whatever it is, it doesn't matter, as long as they're doing something that enhances that mind-body connection. What I try to focus on in that little bit of time that I have with patients regarding other treatments for pain, as well as referring them to all my wonderful colleagues who do this work, is I just talk about the importance of not letting the fear of pain drive you, of even taking a moment to kind of do a body scan, and for part of that body scan, actually dive into the pain, and in diving into the pain, watch how it can change and take shape. So I think this is really important, and also the concept of radical acceptance, this idea that, you will probably be living with this pain in some shape or form for the rest of your life, and I'm so sorry for that. I can't even imagine how awful that is. But let's work together and make a life worth living for you despite the pain. So again, away from this idea that the patient and I together are going to find a way to get rid of pain, and more a kind of walking alongside you as you endure this pain and try to find a way to make life tolerable. So, bravo, again, always bravo to the patients, and also give yourself a pat on the back, because this is hard work, it's very labor intensive, it's under-recognized, you don't get paid, yada, yada, but it's really worth doing because it really is the way to express a deep care for our patients. I'm going to leave you with this quote by Reinhold Niebuhr. Ultimately, evil is done not so much by evil people, but by good people who do not know themselves and who do not probe deeply. These videos are available online if you want to use them in your teaching. For additional references, there's my book, which I think you got a copy of. And thank you so much for listening. I'd be happy to take questions.
Thanks so much. So we're going to now do questions.
Less of a question, but more a comment about the use of the word addiction.
Yeah.
And I've heard Anna speak before, and I think we're on the same page in that addiction is a very real phenomenon. I mean, you just talked about it, so I don't think it's a verboten word, but I think you need to be mindful of how you use the word, and not say you're in danger of being an addict is very different than I'm concerned you're struggling with an addiction problem. Mm-hmm. And I think also avoiding the language around like clean, dirty. Patients use these words sometimes, but I try to use sober or negative urine tox screen or positive for whatever it's positive for. So you don't want to sugarcoat it. Again, sometimes you need to use that word addiction, but I just be mindful of the phraseology, because addict is a very, very loaded term. So.
Right, yeah. And I probably use it a little bit more freely because my clinic is called the Addiction Medicine Dual Diagnosis Clinic. So, it's sort of like, but a lot of patients still don't like that and are unhappy being initially in my clinic with that name. So there is a lot of concern. Yes.
Thank you for a very good talk. I was just wondering two things. I've experienced pain and taken small amounts of opiates. I never had euphoria, unfortunately, while I was taking them for pain. And I know that euphoria is one of the things that is associated with the mu receptors. But in my experience with my patients as well as myself, when people are taking opiates for pain, they don't seem to experience euphoria. I didn't, and I think most people don't report it, don't experience it. So I just wonder your thoughts on that. And also, for me, when I'm explaining dependence and addiction to people, one of the things that helps me differentiate it, and I think helps them understand my concerns, is if I say, addiction is taking the medicine to get high, for fun. If you're taking it because you have pain, you're getting relief. So I just wonder your thoughts on those two subjects.
Yeah, thank you for those questions. I think that to try to classify patients based on their subjective response to opioids is a mistake. Because you can have patients who don't feel euphoria to opioids who can get addicted to opioids. And you can have patients who have a euphoric response who nonetheless will not get addicted to opioids. So I think the subjective reaction and the development of this complex disorder are truly orthogonal. If you think about that balance that I talked about, and you think about it starting out level, and then somebody, let's say, using an opioid to get high, tipped like this. But with the chronic pain patient, you're not really starting out with a level balance, are you? You're starting out tipped toward the pain side. And what they're trying to do, at least initially, is just use an opioid to get rid of the pain. Nonetheless, that phenomenon can occur in people who use opioids to get high and people who use opioids to escape genuine physical pain. And it's a result of quantity and frequency, more and more opioids, then a neuroadaptive response, which, by the way, that neuroadaptive response is, with repetition, is stronger and longer than the first time. So that's one of the other rules governing that balance. Not only does the balance want to stay level, but the balance remembers. So the second time I use opioids, I have 10 more gremlins than I did the first time. So it's pushing my set point always here. And this is essentially what happens with tolerance, right? At first they worked to get rid of my pain, but then I needed more and more because the response was weighted to that side. So although I appreciate, your individual experience and the experience of your patients, and it's valid, I would caution against saying this kind of response classifies this patient as not possibly in danger of getting addicted. I think that can happen even when the patient is genuinely using the medication to relieve pain and in whom there is no euphoric response. Yeah, I'm going to let these guys determine who to go to.
What? We'll both run. See who gets there first.
Thank you. We're working on a pain management project at the Epidemic Medical Center here, in which we are developing pure pain coach teams to be able to assist chronic pain patients self-manage their pain more effectively. You mentioned engaging family members. Have you considered engaging patients, chronic pain patients, as pure pain coaches?
Wow, what a wonderful idea. I love that idea. I totally believe in peer recovery. Working primarily in the addiction world, I know peer recovery works for addiction recovery. So I think it's a fantastic idea. I know there are lots of models too around the country where people are doing this, hiring peer recovery coaches, even within traditional hospital settings. So peer recovery coaches now going around on consult services as part of inpatient teams. I just approached our administration at Standford. They weren't at all interested. I'm not surprised. But But yeah, this is a great model. And really what we have to do is find a cost-effective ways of targeting what is an incredibly labor-intensive chronic condition. One-on-one, you or me seeing these people will never solve the problem. So we have to build integrated communities that weave in and out of the house of medicine in order to be able to sustain people in their recovery from chronic pain. I also believe that there are now some 12-step groups for chronic pain that have emerged here and there. For a while, there was one in Los Altos. I don't know if it lasted. But again, I think this recovery model, you know, what's really amazing about the recovery model of 12 Steps or Alcoholics and Narcotics Anonymous is although inherent in the philosophy is the idea that addiction is a disease, there's also a very strong ethos of people taking responsibility for their disease. So although I can self-identify as having a disease, I'm responsible for getting better. And that's where we want to shift in terms of the narrative. We want patients to stop coming in and saying, "Doctor, fix me," and instead we want a companion with them or walk with them as they work to try to help themselves. Yeah.
You mentioned that sometimes we can, as physicians, we can be handcuffed by our patients and their demands and our urge to please them. How do you address things such as being handcuffed by insurance companies that don't cover acupuncture, that don't cover other alternative treatments for pain, or even some of the non-opioid medications that are out there that are effective but yet not covered by insurance? What are your tips, or how do you perceive a great way to get around that?
I get angry is what I basically do, and then I write a book, which is what I did, and I'm here talking to you. But I have also been known to scream at insurance company representatives on the phone and to threaten to go to a local journalist and expose them as completely unethical. So, yeah. So I do think, you know, I used to believe that if I just put my nose to the grindstone and did my best and took care of each individual patient, that would be good enough. And I no longer believe that, and I'm actually very much an introverted person. I now believe that healthcare providers have to speak out and rise up, because otherwise we are going to get railroaded and told how to practice, and we're going to be forced to deliver care that actually hurts our patients. So I would urge you and anybody who's willing to really fight this machine and say, I'm not going to practice in this way. So that's my answer. Yeah. Yes.
I do HIV/AIDS case management, and it occurs to me that the model that came out of the Ryan White funding of case management is perfect. I mean, we also deal with a lot of this, but I don't know, as we're developing models, it seems like that model is very, very appropriate for the extra visits you don't have time to do, right, and for the extra time you don't have time to give, because we have a lot of time with our clients.
Yeah, I think the team approach is absolutely key. That way each provider brings their special skills and can focus on doing what they've been trained to do and what they do best, and let their physical therapy, social work, psychotherapy, acupuncture colleagues do what they do best. I also think not only does that end up delivering better care in terms of resource management, caseworkers, case management, absolutely vital for these patients, but it's central to avoiding burnout for us personally, right? And we have developed a team, and a lot of places have done that, and it's a lot of like the DBT model, dialectical behavioral therapy model, where the point of getting together once weekly and talking about complex cases is to figure out how to solve the problem, but also to get emotional sustenance from our peers and validation in the work that we're doing. Really, really vital, because it's a very complicated, emotionally demanding population. Yeah.
So this kind of goes back to the insurance company issues and barriers for that. When you're doing the contingency management, how do you handle when I can't come back in next week because my insurance won't cover it, I have to pay another copay, I don't have that additional $30, plus if you give me, a week's worth and then a week's worth, I'm paying out every single time. I get a babysitter for just coming here, you're telling me that I'm coming back weekly and it's gonna cost me $150 every single time, and by the way, I'm homeless and don't have transportation.
Right. Yeah, so I mean, great point. And this is, this is when I do a longer talk on tit for tat, I talk about exactly that kind of situation where we came in cocaine positive and we just ignored it because he didn't have a car, he worked the night shift, he couldn't do the copay. And so we kind of capitulated because of these horrible extenuating circumstances, and he got worse. So and if you look at the data on, for example, Medicaid prescribing, so Medicaid patients are prescribed opioids at twice the rate of non-Medicaid patients in this country, and they die at 6 times the rate. Pregnant women on Medicaid in the state of Utah, 50% of them have been prescribed an opioid at some point in their pregnancy. So my point is, I get it, and yet we are not doing these people any favors by just continuing to prescribe and enable them. I think what I've learned to do in a very transparent way is, I hear you and that's horrible, but I can't safely give you another prescription. You could be dead before you make it back here in a week. And you just have to kind of walk that line. Yeah.
I think I've fallen into all the traps that when interviewing patients on opioid chronic addiction, including being personally offended because I'm a very good doctor and you're not taking my advice. I have learned a lot since coming to this area and dealing with this problem, which I didn't deal a lot with before, and adapted the learning coadaptive neurological changes that become chronic with chronic addiction. However, we keep encountering a lot of rehab centers, a lot of rehab counselors who insist that the patient be totally clean instead of putting people on a maintenance program with buprenorphine or methadone, getting the patient back to functioning, socially working family. Could you comment, please?
Yeah, so, in my lived experience, anytime we go from one extreme to another, we're not getting it right. And when we find the way to walk that middle path is when we're at least hovering in the right direction. So, first of all, thank you for being honest about your own foibles. I struggle with the same thing. I totally agree with you that this kind of abstinence-only approach in rehab centers has got to give way to a middle-of-the-road approach that incorporates medication-assisted treatment, and insurance companies have to pay for it. So these are the things that we have to agitate for. I think that's happening in your community, so that's great to hear. Part of this is vestigial. The original and only intervention for addiction was really 12 Steps, Alcoholics Anonymous, and Narcotics Anonymous. And there's been a huge shift even in that community around medication-assisted treatment and more acceptance of that necessity. In my ideal world, no one would be on opioids for opioid addiction. But if we're going to be scientific about it and look at the literature, multiple placebo-controlled trials across multiple continents, across multiple decades have shown that people with opioid addiction on opioid agonist treatment do better, live longer, live happier, and contribute to their communities. So I think we really have to embrace that treatment, whatever we may feel about it on a principled level.
Hello. I'm a therapist, so I'm coming from that perspective. I wanted to go back to the influences. In our culture, and if you could bring the map back up, that'd be awesome.
Sure.
You'll see that the West has the most of this going on. And we also, I think, have the biggest fear of death. We don't face that at all. We're in complete denial about getting older, especially the cohort that's old now, like the baby boomers, the ones who grew up with the morphine. Mm-hmm. And the commercials, 40's the new 30, 50's the new 40. No, you're 50 or 40. And
says a 30-year-old. Okay.
Uh-huh. And the commercial is showing old people being active, and no, you're not old, you're not old. Yeah. And then that leads to our celebrities like Prince and Michael Jackson dying because they can't face their disability of being older. Right. And then getting to your comment about me, I just turned 38 and I have had to stop playing tennis and being active because of a neck injury, just genetics. And so I've been dealing with chronic pain, and it is weird. And I've had patients before who had that before, and I could not, looking back retrospectively, I could not identify with that. It's like not being able to escape. Your mind wants to leave the pain behind, which means leaving your body. So you can't do that. It's really depressing. It's having to change your whole, the radical acceptance thing, that is tough. So just wondering about, because it's a cultural, as you see, huge, just mindset. So that's about it.
Well, thank you for that. And you're a youthful-looking 38-year-old, so maybe 38 really is the new 30. Yeah, I mean, I think you articulated it really well. I don't know that I have much to add except to say it's an unpopular message. I was on a radio show once and I said something very similar to people have to begin to accept their limitations. I know we all see patients who just want us to fix them. They want the pain to go away so they can go back to doing all the things they used to do. And to say to a patient, well, maybe you can't do those things anymore, people get really angry. It's a very unpopular message, along with the message that, there's no pill. There's absolutely no pill that will help you or take this away. And when I've actually said that, it is followed by a gaping silence. And I've just learned to tolerate that silence and not try to fill it in with something else, but just let the patient kind of absorb that reality. There are two groups that are among the lowest consumers of healthcare. They're Christian Scientists because of their religious beliefs, and healthcare providers. Healthcare providers don't consume as much healthcare as the rest of the country because we know on an intimate inside view what the cost is of that. So I just really think it's going to take a cultural change, but also on our part a willingness to be totally transparent with our patients and tolerate their unhappiness around that message while still giving them hope that you can find a way, to have a life worth living, even if we can't ever get rid of the pain. I mean, pain is awful. It's absolutely awful. And so, I would not ever presume to say that it's not real or it's not horrible, but the supposed cure that comes with opioid therapy is not a cure at all. Yes?
This may be a topic for a whole different day, but I just wondered if you could comment on the use of benzodiazepines in people who are trying to decrease their opioid use. Either they had a prescription and so now suddenly they're using more because of the anxiety associated, or they want something for anxiety.
So part of my contingency management approach is when I inherit patients on buprenorphine and benzodiazepines, and that's a lot of my patients, I say to them that part of the understanding of my taking over this prescription is that we will slowly taper the benzodiazepines. And we will do it in much the same way that I talked about with Bravo. And typically, we will work on that first. And it can take I do that first with my buprenorphine patients because I'm planning on continuing the buprenorphine. But for your complex pain patients, I would say let them choose, which one are you wanting to tackle first. I would also really emphasize that I'm seeing more and more patients in my practice who are coming in with very bizarre chronic benzodiazepine syndromes, which I believe are real. So these are individuals with no history of addiction, no family history of addiction. They got put on benzodiazepines for anxiety or insomnia or vertigo. They've been on benzodiazepines now for 3+ decades. And every time they try to go down, they have these horrible, horrible withdrawal syndromes. And then sometimes they develop like a motor tremor. So it's been interesting to see whether or not there's some kind of toxicity that is evolving due to chronic benzodiazepine exposure. The approach is essentially the same, though. It's the Bravo approach. So I just like there's no evidence to support the use of opioids in chronic pain. There's no evidence to support the use of benzodiazepines in chronic anxiety or insomnia. There really isn't. Again, short-term, benzos are fantastic. Long-term, probably cause more problems than they solve.
I had a quick question. You showed a chart of how many prescriptions for opiates are being made, and I was wondering, do you know like what percentage of people then become addicted from those prescriptions?
Right. So, so this is prescriptions for opioids in 2013 in the Medicare database. And the data, originally Purdue and others said that less than 1% of folks getting a prescription for opioids for a medical condition would become addicted. We now know that 20 to 30% of those individuals are vulnerable to addiction. So that's a really high number in terms of when you're thinking about the iatrogenic crisis here. It's not that 20 to 30% are addicted, but the data show that 20 to 30% are engaging in misuse, or what's sometimes referred to as aberrant behavior, which can be one of the early signs of addiction. If you look at the general population and who meets criteria for a drug use disorder, it's about 10% of the population. So I expect that it will ultimately pan out somewhere between about 10 and 15% of our patient population is going to get severely addicted to, but those numbers, the data really aren't out there yet.
Thank you so much. I know that there are other questions. We'll have time after Bill.
Yeah, thank you so much for the great questions, and for being a great audience.
Thank you so much. Thanks. Yeah.